We're at the 22nd CROI. I am Fred Scheich with IFARA, and we're here with Joel Gallant, as always. We always appreciate the opportunity to visit with you because you have a keen sense of what seems to jump out and become important, at least if not now, maybe in the future, and the new drugs and the use of the old drugs and combinations and fixed-dose combinations, whatever it is that's coming out this year's CROI. So if you would be so kind as to do that again for us.
Well, the CROI's only been going on for one day, and yesterday the big news was more about PrEP. And you know, there's 3 studies in a row showing that PrEP is an unqualified success at preventing HIV and safe with little development of resistance. We're now looking at efficacy in high-risk populations that's far greater than what we saw in early trials. You know, looking at 86%, over 90% efficacy. 2 trials looking at gay men and 1 at heterosexual couples in Africa. And perhaps most interestingly was the Ipergay study from Paris, where it was on-demand PrEP rather than continuous PrEP. So men took either Truvada or placebo 2 to 24 hours before sex, and then a tablet 24 hours later, and another tablet 24 hours after that. So 4 tablets altogether, and showed very high rates of prevention compared to placebo. So, you know, I hope that this meeting finally will put away the controversy and the paternalism and moralism and name-calling that we've been experiencing for the last few years, and we can move on to education and implementation. I mean, I really think that after this meeting, people who continue to bash PrEP are going to be looked at as kind of the anti-vaxxers of our movement, because they're clearly going to be ignoring evidence that this is a useful form of prevention.
And you come to Portland every now and then. We talked about coming to Portland, and I went to the health department. People come to me because they know I'm in HIV work, and they say, how do I get this PrEP? And I said, well, just go down to the health department. And they called me back and say, they don't know anything about it. And what?
Yeah. Well,
this is not uncommon either.
Yeah.
So.
I mean, Rafi Landowitz gave a great plenary about PrEP, and he talked about the fact that what we're facing is this sort of it's not my job sort of attitude among clinicians as well, not just health departments. So HIV doctors who know how to prescribe Truvada, and they know all about it, and they know the data on PrEP, but they say, look, I'm busy taking care of HIV positive patients. I don't see HIV negative patients in my practice, and even if they wanted to come here, they'd be freaked out by the fact that it's an HIV clinic and that people might think they have HIV.
Exactly.
And meanwhile, you got the primary care doctors who are seeing the right patients, but they either feel they don't know how to use the drugs, they don't know enough about it, they don't agree with it, whatever. So we're often in some communities, there's just nobody who's out there doing this. And that's really got to change. Because, you know, giving PrEP is not very difficult. It's far simpler than treating HIV.
But it is the fact that you do have to follow them. Just like, I mean, you still have to test people to see if they become positive, whether they're on PrEP or not. I mean, that makes sense, but there's a prescribed period of time that every so often you have to test.
Every 3 months, but the procedure is very algorithmic. You just follow the rules that are out there by the government, and it's not complicated stuff. So we just got to.
I mean, you're with HIV/MA, and this is something that maybe you could make suggestions and describe certain scenarios or policies or procedures or models that, you know, because I know we have organizations which already do testing for HIV, and maybe they can just incorporate this in a night where the doctors come to I'm just suggesting some ideas.
Well, I think anybody who's testing and then a negative result comes back and is not discussing PrEP and referring for PrEP or providing PrEP, that's a real gap. I mean, what better time than when you find out somebody who perceives themselves to be at risk is negative? What better time to discuss PrEP? And so that's got to be incorporated into testing procedures. So as for what to do, and it's all very clearly spelled out in the CDC documents. So
and also educational programs. I know we're going to do a number of them. Actually, here we're going to be doing programs where we're, you know, because the doctors are here, we're going to do a program with one of the local doctors who's, I think her name is Joanne Steckler, who's going to talk on PrEP, and maybe get people. I know that it's already, there's a groundswell, a movement, and a trend in that direction, as though it's the cool thing to do. And it is, in a way, if it's appropriate. But people have, it's a cool thing to just, okay, consider it. So my hope is that we'll end up with, you know, it'll move in a gradually just, you know, there'll be this groundswell, and the right people will get on it. And there is that description that has to do with the decision by the patient as well as a physician, and maybe some general outlines or guidelines. So anything else at the CROI or maybe that is going to happen that you know about?
Hasn't happened yet.
We'll embargo your talk just in case.
So we're going to hear more about Taff, which is kind of the hot thing, Tenofovir alafenamide. So as we know, the Tenofovir TDF that we use today, that's part of Truvada and Viriad and Stribelt and Comparad, is a prodrug of tenofovir, meaning it turns into tenofovir after absorption. The Taff, tenofovir alafenamide, is a different prodrug. It also has to be converted into tenofovir, but it gets higher levels within cells and lower levels in blood. And the idea there is that it would be more active against HIV and less toxic, in this case, to bones and kidneys. So it's looking that way in the clinical trial data we've seen so far, that it doesn't reduce bone density much at all, the way our current tenofovir does. And it also seems to have less of an effect on kidneys, and specifically on the proximal renal tubules that is a part of the kidney that the tenofovir seems to be able to damage. And so the hope is that we will be replacing TDF with TAF in the near future, and tenofovir will become a safer nucleoside. So we're going to see more data on Taff at this meeting coming up, and that's promising. We hope to see a kind of a Stribelt that contains Taff instead of TDF approved by the end of the year, and then other co-formulations will follow. So there'll be a Truvada that contains Taff, a Complera that contains Taff, and also promisingly a protease inhibitor Taff regimen that will be the first single tablet protease inhibitor regimen. It will have darunavir, which is Prozista, cobicistat, the booster, Taff, and emtricitabine, or FTC, all in one pill. So that'll be nice because, you know, we've often relied on protease inhibitors for people whose adherence is sketchy, and because it's so hard to get resistance to protease inhibitors. So having one pill a day that they could take with very little chance of resistance would be very attractive for that group.
You've had experience now with the Southwest, which is a very different population than you had in Baltimore. But so you feel that the single pill is a feature or a critical way to go for a population?
Well, I mean, I think, you know, the unfortunate thing is that up until recently, up until now, in fact, we've been saying that those patients who are least likely to adhere are the ones we give 3 pills to instead of 1. Kind of counterintuitive. You'd think, well, the people with the most adherence challenges, the ones who most need a convenient regimen, like a single pill regimen. But all the single pill regimens we've had have been prone to resistance if people miss the doses. So there's 2.
Not very forgiving.
Not very forgiving, yeah. So that's why we did it that way. So having a protease inhibitor regimen all combined into single pill would be very attractive. We also have Triamec. Now, Triamec is the single tablet regimen that contains dolutegravir as well as abacavir and lamivudine. And it's the newest of the single tablet regimens. We're not seeing much resistance to dolutegravir either. In fact, in clinical trials, we're seeing none. So some people have speculated that maybe dolutegravir and also Triamec would be a single tablet regimen that you can't get resistance to, and it would be like a protease inhibitor. I don't think we can say that for sure yet. It's a little early. I mean, you know, over the next couple of years, we will either hear about cases of resistance or we won't, and then we'll know. But I think right now it's safe to say that it's not easy to get resistance to dolutegravir, but I don't think we can say that it's completely resistance-proof yet.
Because you don't. I think the best day a drug has is when it's launched. Everything is downhill after that.
Well, we haven't seen a whole lot of downhill with this drug. I mean, the question is what faults does it have, and we don't have very many. But I think before we say that it's as good as a boosted PI for resistance, we have to give it a little more time.
So, are you seeing any changes in the potentially in the recommendations based upon where we're going?
Yeah. I no longer sit on the DHHS guidelines panel. I am on the IAS USA panel, but that's not due for an update until 2016, so we haven't had to think about it much yet. I think some of the questions will be what will happen with Prescobix and Evotaz. These are the new co-formulations of darunavir with cobicistat and atazanavir with cobicistat. So that you no longer need to take a separate pill of ritonavir, Norvir. I assume that they'll get put on as recommended. I mean, there's really no downside, and definitely an upside in terms of pill convenience. I think one of the questions is what's going to happen with efavirenz, Sestiva and Atripla. Tried and true drugs have done us well for many, many, many years. But frankly, everything that gets compared against them these days looks better in some way, either more efficacious or just better tolerated. And that the kind of the neuropsychiatric side effects of efavirenz, which usually go away but can sometimes persist for a long period of time, are kind of a real downside for that drug. And I know it's the most commonly used drug worldwide, but in the U.S. I think enthusiasm for it has waned. Whether it will be enough for guidelines to sort of demote it to an alternative class, I don't know. But it's certainly alternative in my own prescribing, and there are just too many drugs around that you don't have to spend time getting used to.
I've been noticing some of my colleagues talking about lower dose efavirenz, and I don't know how that's going to play out and what that would do or be meaningful or not.
Yeah, well, there's a really good study, not done in the U.S., of course, but looking at 400 versus the standard 600 milligrams of efavirenz, and they found that it worked just as well with fewer neuropsychiatric side effects. Now, as long as efavirenz is a brand name drug, we're not going to see a reduction in dose. But when it goes generic in the U.S., it opens up the possibility that you could have a 400 milligram formulation. And, there could be significant cost savings. Efavirenz would be cheaper anyway, and then you reduce the dose, so it makes it even less expensive. So we could see that become relevant in the U.S. in a way that it hasn't been up to now.
How about in long-term, long-acting injectables? Is that something that you really hope and moving along quickly? Because it seems like it would be a great thing even for PrEP. Eventually.
Yeah. So cabotegravir is the integrase inhibitor that's being looked at can be given by injection every 3 months. A long-acting form of rilpivirine is being studied for long-acting injections. The combination of the two could be a full long-acting injectable regimen.
Because it makes no sense to have one injectable.
You have to have both, right? You have to have the whole thing. And then cabotegravir is being looked at in 2 studies for PrEP. So an injection every 3 months. I think we should talk about those separately because the treatment and PrEP issues are very different. I think treatment with long-acting agents will be something that's attractive to a subset of people. I mean, when I think about my patients, most of them are they're on a lipid-lowering drug, they're on high blood pressure medicines, they might be on an antidepressant, they take aspirin, they're taking vitamin D, and some in Santa Fe are taking a handful of herbal supplements and vitamins, and for them to say, oh, I'm going to take 1 pill of those away and give you an injection every 3 months, and they're going to say, what? Why would I want that? The other group that I think people get all excited about doing this with are the really non-adherent patients. But they may not be the right group because they're often missing clinic appointments. And if you give them a 3-month injection and they don't come back, you've got months of subtherapeutic levels and the risk of resistance becomes very high. I think in prisons, methadone clinics, places where people are there all the time and can be found, that might be an attractive approach. And there might just be some patients who don't take any other pills and would want that. Now, I think in PrEP, it's really interesting because then it becomes more like a like injectable birth control, where women come in every few months for an injection and don't have to really, they're healthy, they don't have any illnesses, they're not taking any other meds.
Because they're not experienced
right.
at taking daily drugs.
And they don't have to think about it. And there, I think that is very attractive form of prevention. The only downside, again, is that if, no one takes PrEP forever. And if you stop taking PrEP, so you're going to have these slowly declining drug levels over a period of months.
Yeah.
Would that, if you stopped PrEP but you were still at high risk, would that increase the risk of resistance?
Yeah.
So it's something we have to think about, but I'm glad that they're looking at it.
Yeah, that's the big issue.
Yeah.
But I'm thinking also in terms of being useful in PrEP being for prevention for the people who are like incarcerated or people who don't want it to become obvious that they're, protecting themselves. Possibly even the younger people.
Yeah.
Because we had that study the other day, and I think that, and also drug ID use. I mean, it's because there's a population that is just scattered and disorganized, and so hopefully.
Yeah. No, I'm very excited about it.
Yeah. Well, I appreciate your spending the time with me again, and we'll visit again at the next conference. But in the meantime, thank you for taking the time, and I'm sure you're now well seated in your new location in Southwest Care Clinic.
Southwest Care Center.
Care Center, right, exactly. Thank you very much,
Thanks,
Joel.
Fred. Oh, it's a pleasure.
Yeah.